And I want to thank all of the presenters for their very excellent presentation. In a minute, we'll open this up for questions, but Tricia just asked me if she could include one more comment to her presentation, so we're going to do that right now. It's
that one?
Yep,
okay.
That's it.
Jenny had mentioned about being on disability. The grand irony in my case, I don't qualify for disability because I didn't work enough. And I didn't work enough because of my disability. And, you know, we carry this out of pocket just on my husband's salary alone. And while everybody's telling you to save for retirement and all these other things. So it's beyond frustrating that I have to, you know, that we can't get any assistance for this. And that I live in fear of something happening to my husband and his inability to work and the pressure that it puts on him. But anyway.
Thank you. I'm going to start by asking a few questions, and I think I'm going to have to direct them to Gary because that's where they arose in my mind when you were presenting. And they're mostly around, well, the first question I had was around case definition. And, you know, as you absolutely correctly said, you know, you can't really move forward with epidemiology without a good case definition. Do we have a stable case definition, or are some of the variability we're seeing in prevalence a function of a sort of a floating case definition that isn't being, you know, well accepted across studies?
I'm a great fan of the DC TMD, Richard, what does that stand for? Diagnostic criteria for TMD. It dates back to '94. The most recent iteration was a few years back, 2014. Now, epidemiologists often do crudely dichotomize, but it's a very, well, it's evidence-based. It is, it's very readily usable for real studies, but also its latest iteration is purposefully clinical and research. They dropped the R from the original RDC TMD. We can train examiners to do this reliably. The process takes maybe 10, 15 minutes if it's a, quote, difficult situation, but oftentimes it's much quicker. So from many practical research purposes, the DC-TMD, it's evidence-based, practical, it's been around, and I'm a fan.
We're going to open up now for committee questions, and I'll recognize Roger.
So I'll direct this to Gary, too. So you talked about a couple of different symptom icebergs and sort of the subclinical population. And I'm wondering, is that a group, how do we handle that group? Do we want them to enter into the healthcare system where either good things or bad things may be perpetrated upon them? Where do they fit?
Look, I think we need to be more aware, they need to be more aware. Some of them probably should be coming into the healthcare system because they might be, this might be their TMD symptom that's adding to the burden of their back pain, their headache. So let's not say, oh, it's subclinical, it doesn't matter. But I would never say everybody needs to rush now to a doctor. I would thoroughly endorse Jim's comment that I think this speaks to a larger need in our population at large, all of us, to understand pain, recognise it's a serious disease. It can become a serious disease, and not to just trivialise it. Even if it's something we're not seeking care for, there are things we could and should be thinking about doing at home.
I don't know who was first over here. I just turned around. They were both turned over. Francesca, we can start with you.
Thank you. So Tricia, thank you for sharing that story. I'm so sorry that you've had to go through such pain and suffering and with so little help. In your comments, you mentioned your primary care physician. So I have a question for Tricia, and then I have one for Gary and James, which is So you mentioned that you had a wonderful primary care a family doctor. I wondered what they did that makes them so wonderful. So what they do. So that's one. And then my follow-up questions to the rest of the panel is where do most patients with TMD get their care? And given that it's such a systematic disease, well, what is the role of primary care physicians in their management?
In my case, with my primary care doctor, I've had some very bad experiences with some pain clinics where for 45 minutes the PA yelled at me saying, why did this doctor cut you off and why did this one cut you off, when I had been sent to this person by my knee surgeon who, during the transition when I was living without a knee, he could not get my pain under control and wanted some assistance. So what my primary does is he's very good at, I think more than anything, reassuring me that he has the documentation to prove my compliance should something come along. I mean, I know other patients who've had their pharmacies raided, they've had their doctor's office, shut down for prescribing pain meds. I would probably do better on a higher dosage of pain medication, but it's also a balance between him and my family being scared if I'm on that much more. I'd say as much as anything, it's just a reassurance that he's got my back, and if I come to him crying in pain, that he's going to figure out a way to help me. If patients like I go to the emergency room, and a lot of talk in the fibromyalgia, and most of us in the TMD world do everything possible not to be diagnosed with fibromyalgia, because if you go to the emergency room, you are immediately labeled as a drug seeker and will not be treated the same way. You will not get proper pain management. You'll be told to take some Tylenol and be done with it. And I've actually literally obliterated my stomach with anti-inflammatory drugs, so even that is off limits now for me.
I'm going to defer to Jim, who probably knows much better than me as to what types of healthcare providers people with TMD see.
Well, thank you. Can you hear me okay? Yeah. All right. We work closely with both medical primary care docs as well as dental primary care dentists, because this is where they first see the patient. And so we will refer, of course, send letters back and forth and discuss the issues. The opioid issue is a very difficult one, because we do not believe in cutting off patients with pain just because of the crisis out there. However, we closely monitor them with opioids, and we really try to taper them off using a combination of treatments, medication-assisted treatment, as well as alternative self-management strategies that really work pretty well. These patients do see primary care, both dentists and physicians initially, and this is where we need to really spend a lot of time in educating them. And so we have this program that I mentioned to you that allows primary care doctors to integrate self-management strategies in with their treatments and to really understand pain. And we have a variety of courses out there on doing that. And we work closely with health plans to be able to reimburse preventive medicine counseling in addition to their office visit, in order to reimburse the extra time it takes to really help understand or help explain some of the self-management strategies that patients can do. And so with that, we hope that primary care, both dentists and physicians, are going to sort of shift their focus more to preventing chronic pain and addiction instead of adding to it and contributing to it by passive treatments.
Okay, we have 4 more questions. I think Barbara, then Srinivasa, and then David and Richard.
I have a question about, we heard Ms. Kalinowski talked about an initial surgical treatment that, as I understand it, actually led to worsening of the symptoms. We've heard both of you talk about having procedures, and if the anesthesia isn't administered in a certain way, this can also aggravate symptoms. And we heard Dr. Frickton talk about iatrogeny on one of his slides. So I'm thinking from the lens of the epidemiology of interventions, and I wondered if anyone could speak to the extent to which the course for those people where there is progression and so forth, is the contributions are from inappropriate treatments or care that if it had not been delivered or delivered differently, the outcome might have been different. Do we know anything about, is that a major contributor to the epidemiology of the outcomes of this, or are these just exceptions that we're hearing?
Jim, do you have an answer for that?
So the question, as I understand it, is what contributes to positive outcomes and or negative outcomes in terms of progression over time, and how do you integrate that within the treatment strategies? Is that the question?
It's more about, do we have any literature or data on the extent to which those kinds of, treatment that worsens, that is inappropriate, wasn't evidence-based, or the way care was delivered, which could have been done alternatively around the anesthesia, what is the contribution of that to the course of this condition from an epidemiology perspective? We know there's anecdotes.
Okay.
Yeah.
Yes. Well, the studies like the one I illustrated by Park does show the high cost of chronic pain, and most of that cost in the analysis was in terms of surgeries, interventions, and failed treatments, basically, and it's an ongoing cost. And they found that over the first year, or the second year of the cost was higher than the first year. I didn't present that within the data. And so the use of the problem what we have here with the high cost invasive interventions like surgeries, injections, things like that, is that this is where the reimbursement is the highest. So when you reimburse at a higher rate, of course, those physicians or dentists or health professionals will use and rely more on those interventions more. And so that's where total cost of care is really important, and some of the cost containment strategies with regard to really understanding the whole person and have capitated reimbursement. And so there is some analysis, but not a lot of data really looking at what are the high-cost procedures done and how much does that contribute to it. But the Park study provides at least some information on that.
This is an epidemiological question for Gary. You indicated that the prevalence of TMD was about 5% based on these studies. Do we have a more granular picture from that or other studies to suggest what proportion of these may be directly related to a TMG, a joint disorder, versus a non-TMD?
So in all of our studies, the vast majority of people, when they're carefully assessed, I would say, by examination, the origin of the pain is coming from the muscles and the joints. Now, the quote, presenting complaint might be joint or one or the other. People might say joint. But careful assessment, in our studies, at least about 90% of people, when carefully assessed, have pain originating in both joints and muscles of the masticatory system.
So
I can add something to that also. We've done several studies looking at the contribution of joint versus muscle. And it was interesting when I first arrived at the University of Minnesota, I was in the Department of Oral Surgery, and when we evaluated the same patient, I would evaluate the patient and say, this is a muscle problem primarily with a joint component. And the oral surgeon would say, this is a joint problem, and maybe there's some muscle component. So when we evaluated that using the diagnostic criteria, and using clinical criteria, we do find that muscle pain is much more common and causes more confusion because it involves the jaw, the temples, the neck, and many other aspects of it. And so the joint contributes to pain in a lesser percentage than the muscles.
So just first a comment on the overuse of procedures. I published a paper a long time ago in which my co-authors and I used the term therapeutic hyperenthusiasm, which I will commend to you as a useful euphemism. My question really is for either Dr. Slade or Dr. Frickton, and that's on the, do we have a good number for the extent to which injury is an inciting factor, recognizing that there are obviously other factors that, deal with subsequent development. But I'm thinking in particular, I mean, auto trauma is common, falls are common, blows to the face are common. Do we have a number? Do we have a good sense what that is?
So I had one slide there on injury and the fact that people who experience injury have about 4 times the rate of subsequently developing TMD as people who don't experience injury. Now, when you parse out the types of injury, there are small numbers of individual things. If you go after motor vehicle accident versus, sporting type injuries, we lack the numbers in the OPERA study. But one thing that I think is well worth shouting out here is in that study, we asked people to report injury either from external causes or injury that was, say, from yawning or extended mouth opening or other perhaps daily occurrences, not clearly extrinsic injuries. And by far, that was by far the greatest number of injuries experienced. And it likewise contributed to risk of developing TMD just as external injuries do. So I think it's an important question about which external injury is perhaps the more important than the other, but let's not forget these non-extrinsic injuries.
And I can add to that also, Gary, very good comments. We found in a study looking at just our patients in just a case series that dental treatment was really the most common onset event that the patients reported caused the original. And that was 31% of the patients that we saw that had masticatory TMD problems. In addition, there's a study done by Huang, also found that after third molar extractions, 23% of patients did have jaw pain. Now the question is, most of the people who have an injury, they get better. They improve their condition. It heals normally. However, the delayed recovery is really the critical element that we have to look at. Is not only what percentage of patients progress, and the OPERA has great data on that, but what are those risk factors that cause this delayed recovery, and how can we?
Are you still there, Jim? Oh, the margarita around. We're going to go just around the horn here, so we'll start with Bill and go straight down the line.
More of a comment. I was really struck, from our 2 patients, Jennifer and Tricia, about the history, the life history that they've experienced, and then with Gary's presentation of the iceberg. And so a comment to the committee is to give some thought to how do we protect patients from iatrogenic events, going from the subclinical or near clinical diagnosis of a oral facial pain problem to what we have heard today. So to identify ways in which we can diminish, say, surgeries, to the jaw? What are the processes, policies that could be conceptualized to protect the iceberg from getting to the tip of the iceberg is, I think, a very important feature of this committee work. The second is, how does one structure reimbursement from third-party payers to both patients in clinics for doing that good work, for protecting patients in the iceberg from going to the tip of the iceberg? And I would submit that one of the main problems that we have now is, because of the way our healthcare systems are structured financially, is that there is not a mechanism that puts focus on multidisciplinary approaches that will help protect patients in a way that allows our healthcare administrators to say, develop a system for this.
Yeah, I guess it's more of a comment on Dr. Frichten's about the self-management and involving the patient in their treatment, and I think that's really important. And I have to wonder how many people actually instead of that passive patient becoming the active participant in their health care, how many really get to spend time with their providers and really go through the risk and benefits of all those procedures and have the opportunity for that multidisciplinary approach. I mean, I think that obviously is the gold standard of it, but I just wonder, how much time do they really get to spend? And I know it's because it's not reimbursed, but is there an exception that could prevent some of this?
I'm happy to respond to that. Can everybody hear me okay?
Yeah.
Okay. Very good question, very good points to that. Right now we are trying to educate the general dental and general medical community about what is evidence-based care and try to minimize iatrogenic consequences of exuberant treatments that are particularly surgeries, injections, and those types of things. And we have been working with the health plans very closely, as I mentioned earlier, about implementing preventive medicine counseling as part of education about the reimbursement of the provider. So they can spend the time, as you mentioned, with the patient to educate them on strategies for which to integrate self-management training with treatment, not instead of treatment, but with treatments, very important. And to do that shared decision-making, which is a critical element within the initial consultation with the provider, to really say, here are the various different treatments, here's the risk. And in every case, we have to integrate self-care, and we're going to spend the time necessary to do that. And then health plans are beginning to reimburse. For the last year, we've been sending in codes, CPT codes, for preventive medicine counseling as part of our care model, and they have been reimbursing it. So I feel really good about that. The last comment that I make is that we've been working with the American Dental Association and the profession of dentistry to really develop orofacial pain, including TMD, of course, as a specialty. And right now they've developed a commission for evaluating specialties and dental boards. And we have our proposal, which we've submitted 20, 30 years ago, back into the ADA Commission in order to really help establish this as a specialty of dentistry, where we will have many more clinicians to provide evidence-based care and hopefully minimize some of those iatrogenic consequences of poor care-making, decision-making.
And I think we'll do Richard, Sean, and then we'll be out of time.
So I have three comments. The first two are directed to Gary. The first one was that Bob had asked about case definition for TMD. And I think it's worth pointing out that our very good case definition is used in opera is rooted around the pain problems, We can do that reliably. But we don't really have a good case definition for the mechanical joint problems, and the research there has suffered, I think, considerably. And I think it's worth really being clear about this huge discrepancy in our knowledge base at this time. Any? Okay. Yeah. Wise man. Second comment is back to injury, and that was that part of what we've discovered in our research on injury is that actually we're in need of a good case definition of injury. It seems self-evident, but it's actually much more complex than it appears, and that I'm not sure if the point was made clearly enough, because I'm thinking about part of what Jim had said, was that though in our data, injury was clearly not a smoking gun in any of the individuals for whom that was a very strongly associated risk factor. My third comment is for Jim. And Jim, you were talking about disability in relation to TMD, and what occurred to me was that the flip side of disability determination is we don't have a good definition of oral health upon which to base that. And I know, and sitting next to me is Bob Wyant, who is part of the Surgeon General's Commission now on defining oral health. But its definition and how to measure it, I think, is critical for us to even begin to think about alterations in function, particularly when we get into the disability stage. And I don't know if you have any further thoughts about that.
That's a very good comment, Richard. We really have to broaden the definition of oral health. It's not just about the teeth and the gingiva, but now it's really about the whole orofacial, craniofacial structures and how the jaw functions and all the different impairments that can result when you do not have jaw function. So I completely agree that we need to broaden the definition of oral health, and similar to what NIDCR did years ago in adding craniofacial to the name of the organization. So how to do that is a question, and we will be presented to the American Dental Association to really kind of help address some of those conditions, some of those questions through the American Academy of Orofacial Pain.
And I don't know if I can, I would urge the concept of high impact pain is also particularly important here. And I'm really just adding on to this. Yeah, so yes, we could include a definition of pain or protection from pain as part of a definition of oral health, but we want to think about high impact pain.
I just would also like to advocate that we not necessarily lose focus of the etiology of TMD is currently conceptualized, and that we don't become too focused on craniofacial alone. And I think that we can continue to dice the onion many, many different ways, but I think it's more important to understand the omelet than the diced onions. So I would advocate, to make sure that we don't lose focus of the larger picture here.
Yes, thank you to the panel. Superb job. Tricia, very powerful presentation. Many aspects of it that resonated with me. I was struck by a comment that you made that I hear frequently, and that's the challenge to access to your medications and the unfortunate role of pharmacies that are trying to address in their own way the opioid crisis, but maybe having unintended consequences for people suffering from pain. And we're on the same page. I agree. I hear it frequently. Gary, mostly to you, but also to the committee. The topic of high-impact chronic pain has been brought up, and this is one near and dear to my heart. This came out of the National Pain Strategy, which came out of the original IOM pain report. And we published a paper that you alluded to as a CDC MMWR fall of 2018. I have to compliment James Dahmer and Chad Helmick from the CDC with leading this. And, we were trying to address this issue of high-impact chronic pain and address some of the criticisms of the IOM pain report and the 100 million Americans that, for many people, it didn't pass the sanity check. And to the point about pain on a continuum, what we found is that, well, pain is on a continuum, and that about 20% of patients or so, 8 million, 20 million Americans, 8% of patients had high-impact chronic pain. Why I bring it up is some of the biggest factors that were identified in predicting who had high-impact chronic pain were those of low socioeconomic status. Specifically, in looking at age-adjusted prevalence rates, it were those who had a high school education or less. It was people who were on public insurance. It were people who were unemployed. And I guess my question is, some of these are modifiable factors, some of these are not, but should we be addressing some particular focus from an issue of disparities and recognizing that this vulnerable group, you know, needs and deserves perhaps more attention, and we should be looking at ways of delivering health care that are cost-effective, easily disseminatable to this vulnerable population? I know that was a mouthful and perhaps more of a comment, but I invite your response. And
so yes, high impact pain, I agree. The sanity check, the credibility check, there's a big symptom iceberg of pain out there, and I agree with Roger. I think you meant to say, Roger, we shouldn't be rushing to medicalise that every bit of pain that's out there, and I agree wholeheartedly, but high impact pain is one important way to, at a public health level, to give priority, and I fully applaud that, yes, and the work you guys did on coining the phrase and rediscovering that in the data, I think it's essential. And I agree as to the disparities, and in OPERA, you know, we found high impact pain in TMD. Among people with TMD, high impact pain was threefold greater prevalence for African Americans than whites. So in addition to the disparities you've mentioned, a terrible racial disparity. I expect that a good part of that is related to income disadvantage, rejection by healthcare systems, and discrimination all the way down the list. So I don't know the reasons for that difference, but those disparities in high impact pain, I couldn't agree more, Sean.
This is Jim. Yes, I agree that high impact pain is really where we should put a lot of focus on. And it has to be a patient-centered approach. As I kind of mentioned in my presentation, we need to have education of patients as part of routine care, and we call that transformative care. It will transform how we manage high-impact chronic pain, and it will help in facilitating the implementation of scalable solutions that can be integrated into primary care dentists, primary care physicians, and that they are educated on all the different things that they can do when the patient's pain is at low impact. When it's just beginning is the key to preventing chronic pain, addiction, disability, and all the other negative consequences of high impact pain. So we have to really start early on in training all of our health professionals in what is should be a standard model of caring for pain conditions, and particularly TMD, and that's integrating training with treatment, using a team, and some technology could be very helpful to make it a scalable solution. So great comment.
Okay, with that, we'll close this session. Thanks again to all of the presenters, and with that, I'll return the gavel to the chair.
So there's a cafeteria up on the third floor. I invite everybody to go there and have some lunch, and please be back at 12:30.